All right, everyone, thank you for joining us today. I'm here with Dr. Cheezum out of Virginia Beach, Virginia. And Dr. Cheezum has been the founder of a consulting agency called Tidewater Optometric Consulting. His specialty is in helping optometrists in practice with their coding and billing. So I'd like to hear a little bit from you, Dr. Cheezum, about your experience and what inspired you to start this business.
Well, I'd always, when I was in private practice, I'd always tried to keep up to date by going to all the lectures by the billing and coding gurus. And when I left my private practice in 2013, I had several of my colleagues in the area and other parts of the state contact me and start asking me questions and asking me if I would help them. So I figured that if I was going to do that, that I should probably obtain some sort of formal training. So I did some research and found out there's an American Academy of Professional Coders based out of Salt Lake City, Utah, that actually represents billers and coders from all different healthcare professions. And at this time, there's probably about 200,000 members of that group.
Wow.
So they're kind of the premier billing and coding certification group in the country. So I went through and took what's called a Certified Professional Coders course in 2015. And I realized very quickly as I was taking that course that unfortunately what information was being provided by a lot of the folks that we consider billing and coding gurus was not really accurate. They were telling us ways to bill and code to get paid versus ways to bill and code properly to get paid properly. And in many cases, what they were telling my colleagues and I was costing us a lot of money. So I got my certification in that. And then about a year or so, and then I started participating in their online forums. And about a year or so after that, I was contacted by the AAPC executives, and they said, we want to start a new billing and coding certification for ophthalmology coders. Would you consult with us and help us with that? So I worked with them on that certification program. And as a result of my work with that and testing and so forth for that certification, I became the first optometrist in the country to attain certified ophthalmology professional coder status.
Wow.
So that's kind of how I got here. And after I left private practice too, I went to work for a company called ChenMed based out of Miami, Florida, that provides medical care for Medicare patients who are members of Medicare Advantage plans. And so I worked in a clinic in Norfolk, Virginia, in a multi-specialty medical practice. So I worked with cardiologists, oncologists, PCPs, nurse practitioners, acupuncturists, and so forth, trying to help patients keep them healthy and keep them out of the hospital. My main job at that location was to help them attain their 5-star HEDIS rating score for dilated retinal examinations for diabetic patients. But I learned a lot about how general medicine perceives us as optometrists. And I also learned a lot about how much general medicine, even specialty medicine other than ophthalmology, knows very little about what we can do and knows very little about treating the eyes appropriately in terms of diagnosis and prescribing treatments and so forth. I did many stat consults for subconjunctival hemorrhages for the PCPs, and because they were afraid when they saw the patients come in with the subconjunctival hemorrhage, and they thought their patients were going to lose their vision immediately, and they would drag me away from my patients and say, you've got to come in immediately and see this patient. I'm afraid they're going to lose their vision. And when I started explaining things to them, they looked at me and said, boy, I'm glad you're here, because we're realizing what we don't know about the eyes that we thought we knew. So that's kind of where I am, and that's how my consulting has progressively gotten bigger, and I deal with more clients on a regular basis now than what I did when I first started. So very long story, but that's where I am now.
Quite the retirement you're in there.
Yes. So,
Uh,
well, I retired from clinical practice a couple of years ago now, but I still, so I concentrate mainly on the consulting work.
mhm.
So,
And we were chatting a little bit before we started recording, and you mentioned that you'd also been involved in some legal cases recently. Is that right?
some legal cases. Yes, unfortunately, one of my colleagues in Virginia got into significant trouble for poor record keeping as well as improper billing and coding type things. And this particular optometrist ended up in front of the entire board of optometry after many appeals processes. And basically, my job in her case was to try to uh, do as much damage control as it could. She had really made some major errors and things, and was guilty of what they were of what they'd accused her of. But I was there to do as much damage control, basically to help her keep her license to practice, because her license was in jeopardy.
Mhm.
And so I was at least able to do that. She ended up paying a fairly significant fine and had to do education classes on billing, coding, and record keeping. But at least she retained her license and was able to continue to make a living.
Sure. Well, yeah, I'm glad to hear that. That's a tough position, I'm sure.
Yeah,
Uh, Yeah, and going back to something you said near the beginning of our talk here, where you had said that some of the billing gurus would recommend things that weren't really right and were costing a lot of optometrists money. Is that sort of the way where they would get audited and then have their refund, um, or is it just that they were actually missing, being compensated for what they services they performed, or what were the biggest?
well, if you talk to a lot of optometrists, as I do, yeah, and the first question I ask them is, are you using to the fullest extent your ability to use both the 99,000 and the 92,000 office visit codes?
Uh-huh.
And the answer I typically get is, no, I just use the 92,000 codes, because the folks I've heard lectures say that's what I should be using. And my billing staff says it's easier to use those. We stand less chance of getting into trouble if we're audited, because there's certain criteria that you've got to meet with the 99,000 codes in order to bill those. And so a lot of folks, a lot of the speakers were telling the docs to take the easy way out, as well as were supposedly experienced billing staff that doctors had hired were telling them to take the easy way out, and it cost them a good bit of money. And as I said before, they were teaching folks how to bill to get paid, but not how to bill properly to get paid properly. And it cost every single audit that I've done, record audit and billing and coding audit that I've done to date, I found that on average, the average OD is losing anywhere from $30,000 to $50,000 per year per provider
Uh-huh.
and potential income, just by improper use of the 92,000 and the 99,000 billing and coding codes that are available to us. We're the only profession in healthcare that has two billing code systems that we're able to use. And unfortunately, many of us don't do that. And as a result, it costs us a lot of money.
Yeah, those are significant sums.
Yeah. And when you get into like a three doctor practice that I audited, you look at it, and that's $90,000 to $150,000 a year that practice was losing.
Mhm.
And they had supposedly experienced billers and coders, but again, they were just told, let's use the 92,000 codes, and because they're easier. Well, they might be easier for the staff, but when I got in and started doing the audits, the doctors were doing everything they needed to do properly to actually bill the 99,000 codes if they needed to.
Mhm.
So that's an issue that a lot of docs don't pay attention to. They try to leave it to, they want to do the doctor stuff, but they don't want to worry about or know about the administrative stuff that actually is very critical to allow them to maximize their income that's due to them. I'm not talking about billing high codes just for the sake of getting more money. I'm talking about billing for what they have done and what's due to them. And unfortunately, many of them don't, because they don't pay attention to those details of how things are being done by their staff in most cases.
Yeah, especially when you pair that with our decreasing compensation, uh, a lot. Is there one or several coding errors in particular where people aren't coding to the highest level?
Well, as I said, the biggest difference is not appropriately using the 92,000 and the 99,000 codes. Another big thing that a lot of doctors don't realize is they'll have patients come in and they'll do multiple diagnostic tests at the same visit. Say they'll do a visual field and an OCT at the same visit. What they don't realize is there's a program by Medicare and most of the other insurance carriers have adopted this called MPPR, multiple procedure payment reduction. So you get paid, if you do those two procedures, they pay you full fee for the highest paying procedure, but they will reduce the fee for the second procedure. They can reduce the fee for the second procedure anywhere from 50 up to 100%. So when you're dealing with relatively low fees, not too many years ago, the fee for an OCT scan was $70, $80, binocular scans. Now on average, it's about $35 or $37 for both eyes to be scanned. So when you start losing that amount of money from fee reductions, and then on top of that, because you don't do things properly in your office, you lose half of that $34. You multiply that by hundreds of patients per year, and the money adds up very, very rapidly.
Yeah.
And the other thing that I see a lot is a lot of doctors either don't do at all interpretations and reports for those tests, or they don't do them properly. And if they were audited, I had a practice audit a couple of months ago, and their interpretation reports were, if they even existed, were horrible. And I just looked at the doc and said, do you realize if a Medicare auditor came in here today, that you would probably have to write them a check for anywhere from $30,000 to $50,000, and that's assuming that they just went back a couple of years. And they said, no, I wasn't aware of that. And I said, you need to pay attention to what you're doing as far as your record keeping stuff. And that's your record keeping should be reflected, especially now with ICD-10 codes. As I tell folks now, the ICD-10 codes tell a story of what you did for that patient during that visit, but the ICD-10, the record has to show that you actually did that stuff. The old saying that we heard in optometry school is, if you didn't write it down, you didn't do it. And that's still very, very much the case today.
Absolutely. Now, for those practices that you are seeing doing these things properly and successfully, and for the most part maximizing things, what do you think they're doing differently? Do they have a certain protocol that's written where they've really sat down and pieced this apart? Do they have their staff trained so that things are kind of automatically, they're not doing a visual field on the same day as an OCT? Is it a mix of those things?
Well, it is. It's a combination of the doctors being properly educated themselves, taking the time and spending the money to educate their staffs, taking the time and money to do something just as simple as spending a couple of $100 per year to get new code books every year. Because, a lot of patients, a lot of the billing and coding staff, if they don't have new code books, they may be very good at what they do. But if they don't have updated coding books, then they can do things the way that it used to be correct, but it's not going to get paid by the insurance company. An example is I had one of my colleagues, who's a good friend of mine, his wife does the billing and coding for their office, and said, we're seeing these diabetic patients and we're not getting paid for their examinations. And I said, well, tell me what code you're using. And she says, well, if they don't have any diabetic retinopathy, we're using say the E11.9 code for a type 2 diabetic without any retinopathy. I said, okay, well, that's very nice. I said, are you putting down the additional codes that it shows you in the ICD-10 code book that you need to show if that patient is taking insulin or if they're taking oral medications? And she says, do I have to do that? I said, yes, you do. And I said, so refile the codes, put those in, and you call me and let me know if they get paid. And she called me back about 3 weeks later and said, every single one of them got paid. So I said, and you don't have up-to-date code books, do you? She says, no, I don't. Our code books are 2 years old. And so it makes a big difference to spend that money. And there's big changes coming in 2021 in the CPT codes. Excuse me, not the CPT. Well, the CPT codes, as specifically the E&M codes, the 99,000 codes that a lot of docs aren't aware of yet. But it's a little early to go into too much detail on that. But that's something that people will have to relearn again to build those codes properly.
So kind of hammering in having updated code books is sort of your new lecture of don't sleep in your contacts.
Right, exactly. Yeah. Kind of, yeah. Your code books are good for a year, just like the contacts should be good only for one night or maybe a week. So you don't stretch them out into 2 years or to 2 months.
For the health of your practice.
Yeah, it's right, exactly. It's not good for your financial health of your practice versus the ocular health of your eyes. Yeah, exactly.
That makes sense. And with those changes coming up, do you see any particular challenges or stumbling blocks that you anticipate our profession having trouble transitioning with?
Well, theoretically, it should be a relatively easy transition. The biggest thing right now, the 99,000 codes, you have to meet certain criteria that are established for history, the different exam elements, and the medical decision-making portion of the examinations. And when you audit records now, you look at those and say, okay, did they check those boxes like they needed to? And so with the new codes that are coming, and they've already been determined how they're going to be done by AMA, who's in charge of the CPT coding system. Under the new system, instead of having to worry about the history and exam portions, the definitions say, do an appropriate history and examination, and your code that you choose for the 99,000 codes will be based upon 2 choices that you have, either your level of medical decision making or the time that you spend with a patient. And realistically, it's going to have to be done on medical decision making because the time, I believe, for a say 99204 code, I think that's 29 to 45 minutes of doctor face-to-face time with a patient. And I don't know, other than say if you're doing a low vision exam for patients, I don't know of any doctors who are efficient in their practice who are actually spending that much face-to-face time with them. It doesn't, your staff time and pre-testing and staff time educating them after the doc has left the room doesn't count towards that time. So they'll have to learn how to do that medical decision-making very well now. And unfortunately, there's not been a lot of specific information available as to, okay, what specific eye-related types of things constitute a low, moderate, or extensive level of medical decision-making. So that's the main thing that docs will have to learn, is to be better at that, because not many of them are not that good at that right now.
At documenting.
At documenting and doing and making the medical decision making and attaining the right understanding what level of medical decision making is needed to use a specific 99 code versus be a level 2, level 3, or level 4, even a level 5 code.
I was just sorry, I just got a little lost in the bureaucracy there. Thinking this arbitrary 29 minutes, 28.
Yeah. It is. You don't want to sit there with a stopwatch and, like you're playing chess, pop the timer and say, okay, here we go.
Right. Now you
That's
get it. You might have got it at 15, but
yeah, right, exactly. Yeah.
uh-huh. Um, if you were I mean, we've kind of talked about these common issues that you run into. Um, if there were a piece of advice or just kind of overarching pearl of wisdom, so to speak, getting back to optometry school, um, what would you share? What would you say is really the most important thing?
Most important thing is for the doctors to educate themselves. They don't have to educate themselves completely on proper billing, coding, and record keeping. Make sure that you take the time to have at least a basic level of knowledge on how things should be done, and make sure that your staff knows what they're doing, and check on your staff. It's just like handling money in your practice. When I had my private practice, I'd go through the day sheet before the day was over, and I'd look at every single transaction that took place. And if there was something that I saw that didn't make sense or something that was missing, I'd bring it up to the folks at the front desk and say, okay, why isn't this here? And again, it gets back to where a lot of doctors want to just do the doctor stuff, and they don't want to be involved in the office management stuff. So you have to look out for yourself, because bottom line, it's a business, and if you don't keep your business financially viable, you're going to be out of business, especially in these days of either stagnant or reducing fees, because I can't think of a significant fee increase that anybody has really received from any medical insurance carrier in the last 10 to 15 years. And we definitely don't see any fee increases coming from the vision care plans. In fact, we see the vision care plans vertically integrating now, where some of them, VSP now has brick and mortar stores. They've just bought VisionWorks, so they have 700 or 800 different brick and mortar locations that are direct competition to the providers who made VSP into what it is today. And then you see VSP directly contacting patients when you pull a claim authorization for a patient within minutes. And from some stores, I've heard the patients are receiving emails from VSP. It's like, okay, get your exam done, but then come buy your contacts or glasses from us through Iconic, and we'll give you a little extra spiff by throwing another $10 to $40 benefits towards you. So those things are working against providers, and any provider who doesn't think that they need to dramatically increase the medical aspect of their practice is fooling themselves. If you try to rely on the hardware aspect of practice, the glasses and contact lens sales, as so many providers do today, and income from vision care plans, you're going to be left out financially, and not in a good position to be able to sustain your practice and do things that you want to be. You're going to be an employee for somebody that's going to have you running a refraction mill for them.
Yeah, so ramp up the medical side of things, and then bill for it properly. Document it, and then bill for it
properly. Right. And one other thing too is that a lot of the doctors do not keep up to date on what's happening within and healthcare in general in this country. As an example, if you want to become a Medicare provider, anybody can apply. Any doc can apply to become a Medicare provider, and you're approved. You're on the panel. Well, Medicare is making a concerted effort to shift that patient group, which is millions and millions of patients, and getting bigger every day as us baby boomers age, and they've established these what are called alternative payment models, which are Medicare Advantage plans and the accountable care organizations. And sadly, those two different APMs, alternative payment models, do not have if you will, any willing provider that Medicare does. And I've seen examples, I know in our area here, one of the major Medicare Advantage plans run by Humana, blatantly discriminating against ODs. An OD calls them I'm an optometrist, I want to be on your provider panel. Oh, I'm sorry, we don't allow ODs on the panel, or we have enough already. And this is not just something for our area, I hear it from other areas of the country. So the docs need to get out there and make sure that they get on those plans unless they want to be left out. And a lot of them, unfortunately, are sitting back and just saying, well, I'm going to wait for somebody to handle that for me. It doesn't work that way. You have to work for yourself and get on those plans, because if not, Medicare wants 80% or more of the folks that are covered under some sort of Medicare plan to be on these APM models within the next year or two, and they are ahead of schedule for that.
Oh.
Okay, so you need to support your state association, support the AOA, because despite what a lot of folks online may think and say about the organizations, they're working for us. They may not be out there telling you everything that they're doing, because sometimes it's best not to tell everybody what they're doing, because they're working behind the scenes and trying to negotiate these with these issues. And I know for a fact that they are. I know if my state association, if I were to call them and tell them, hey, I'm trying to get on this Humana plan or this Blue Cross Medicare Advantage plan, and they won't let me on, I know my state executive director has no problem with calling his contacts with those insurance companies and saying, why aren't you allowing optometrists on the panel? And they've been very successful in doing that. And I've heard other state associations have been able to successfully do that too. So, but the doctors have to educate themselves about the need to do these things. I still see docs complaining about ICD-10, going from ICD-9 to ICD-10 on some of the online websites, and it's like, where have you been for the last 5 years? Okay, get your head out of the sand and educate yourself. Don't depend on somebody to hand it to you on a silver platter, because if you're waiting for that to happen, it ain't going to happen. And you're going to sit there one day and say, what happened to all my income?
I wish there was a silver platter.
Yeah, sadly there isn't. I feel sorry for a lot of a lot of the younger ODs that are coming out of school now with $250,000 to $300,000 in student loans, because it's tough out there. It's a tough world out there, and healthcare in general, but I think especially optometry faces a lot of challenges, because we are a small profession, and it's very easy for medicine to argue against us being able to do things as far as increasing scope of practice, and easy for medical directors of these different insurance plans to argue against optometry being able to be in the game as far as being on their provider panels.
Yeah, it almost feels like a little like being bullied a little bit.
Well, it is.
Yeah.
It is.
Yeah. Do you think that ophthalmology is having an easier time with these changes in coding, just being more inherently medically based historically?
As far as the billing and coding stuff?
Yeah, or do they?
In general, it kind of depends. In our area here, with my position that I had working for ChenMed, I would see records from all of the different ophthalmology practices that came in on reports on the patients that we saw, and then maybe had to refer for them for tertiary care. And several, the larger practices, they've got it down. They have the record keeping system in place. They have the staff and doctor education in place, and they are willing to spend the money for a lot of the big gun billing, coding, and record keeping companies like Corcoran or Rose and Associates to come in and say, okay, what are we doing? Let's have you guys do an audit for us and tell us what we're doing right, tell us what we're doing wrong, and then if we're doing something wrong, tell us how to do it right, and we'll fix it. But I've seen some other, one of the older retinal practices in the area, the records that I saw from that doctor were horrendous. He was still using paper charts, and when I would see his report, first of all, you couldn't even read what he did. Okay.
Chicken scratch.
And secondly, you couldn't even figure out, okay, there was nothing there in terms of uh, any of the exam elements really being easy to pick out of what he did. And I have no idea what codes he was using, but I'm thinking, man, if you were audited, you'd be nailed to the cross.
Mhm.
And but in general, the ophthalmology practices are willing and able to spend the money to make sure they are doing things right.
Mhm.
And they spend a ton of money every year to do those things. And optometrists don't look, unfortunately, in many cases, optometrists don't look at that money as an investment in their business. They just think of it as a unnecessary expense that they'll get to when they get to it.
Mhm.
And that's why they run into problems.
Right. Yeah. Costs money ways. Well, it sounds like for a lot of practices, an audit would actually pay for itself. I mean,
It does.
like through you, not
Yeah.
from.
No, I've saved a lot of docs a lot of money and made them a lot of money. And as I tell everybody, if when you use our services, I can pretty much guarantee you that you'll make many, many, many more times than what I charge you to do this audit for you or whatever other service that I do for them. And I've not been wrong yet. So
Uh-huh.
so
Although, yeah, I guess it would be good to be wrong, but
yeah, I'd love to be. Hey, listen, I would love to be wrong, but sadly, I've not been wrong yet. So
uh-huh.
yeah,
Uh-huh.
because very few of our colleagues are really doing things the way they should be. They're kind of, well, my billing and coding person called Sally or Joe from Dr. Smith's practice down the street, and they said this is how they bill and code for that service, and they get paid for it. So that's what we've been doing. And I look at it and say, well, that's real nice, but do you realize that you could have maybe made $20 to $50 more per patient if you billed it correctly versus the way that Sally or Joe told you from this practice down the street? And oh, well, we've been doing it that way for years.
Uh-huh.
So it's a sad situation.
Uh-huh.
We rely too much on second and third hand information versus first hand information. And it's surprising. I do some lectures for the AOA and the AOA national meeting and the Virginia Optometric Association meeting and local societies. And sometimes I have docs just get right in my face and arguing with me during the lecture. And finally, usually I bring the code books and the other books with me, and I just say, "Let me show you something after the lecture. Let's sit here and read this. And have you actually read this? Oh no, I'm just going based upon what I've heard. So well, let's read it and see who's right here." And it's interesting. Everybody has their opinions,
Very
and
diplomatic.
I'm not saying I'm right 100% of the time by any means. I would never ever try to imply that, but I've made a point of educating myself so that I know pretty much what I'm talking about.
And you're in the trenches every day.
Yeah, exactly. Yeah.
Yeah. Um, all right. So really the biggest takeaways I'm hearing are, yeah, make sure you are coding properly and you're up to date. For the health of your practice, we should be switching more to medical side of things, which I think is everyone knows that, but maybe not everyone knows those tools go along with making that switch. That's why it's so important to be knowledgeable about the billing. And then, of course, being active and advocating for the profession. It sounds like you have a pretty high opinion of, yeah, the AOA and your local association. Um, and
Well, a lot of ODs forget that they wouldn't be able to do what they do as far as scope of practice goes unless they had those state and national associations there. I hear people fuss all the time, what have they done for me lately? Well, today, were you able to take out that foreign body, or were you able to write that prescription for that patient who had the iritis? Because when I came into practice, the biggest thing that we had to do was try to get diagnostic agents. Just using an anesthetic was not heard of, and it was just starting to come into play when I graduated in 1978. And you go to the hearings, if you spend the time to go to the legislative hearings on these things, the lies that medicine is willing to tell about us and against us. According to the ophthalmologists that testified against our even getting diagnostic drops, patients are going to be dying in the street because we were using those medications. Well, I haven't heard of one that died yet that I'm aware of from being dilated or from a drop of proparacaine or something like that. But they still tell the same stories. And sadly, when you go in and talk to legislators, unless you have a relationship with them, they'll tend to make you prove yourself, make you prove the MDs wrong before they'll believe what you have to say.
Yeah, I graduated, as I mentioned, I'm out here in Washington State. But I graduated from Pacific, which is in Oregon. And I graduated in 2007 when there was a lot of therapeutic changes and injections and things. And yeah, I spent a day up in Olympia meeting, trying to even just put a face to our profession of, we're out here and we care about what we're doing and we're trying to serve everybody.
And a lot of people don't realize that you have to maintain those relationships. They think that you can go in once a year and say something, but you have to kind of get to know them sometimes and talk to them, and over a period of time they begin to trust you, where they'll actually call you and say, hey, this ophthalmologist said this against the bill that you guys have introduced. What's your take on things? And since I or other folks that I know had taken the time to get to know those legislators, once we said, no, that's not really true, and let me show you why it isn't. A lot of them actually, a couple of them that I've dealt with have really gotten ticked off that they were lied to by medicine about things that we wanted to do. And
that epilation isn't surgery.
Oh yeah, exactly. Yeah, and patients are going to drop dead in the street from the diagnostic drops and so forth. So yeah, it's we have a tough role to go, is to get things, and we have to remember too that we have to work hard to retain those things. You've seen that happen in Oklahoma and Arkansas, where they've medicine and even the large firms like Walmart have come after the state, the scope of practice laws in those states to try to water them back down again. So those optometrists that practice in those states couldn't do certain things that they've been able to do for a while anymore. So it's not a one and done type thing. It's a get it done, but keep up with it, because otherwise you're going to lose it. And unfortunately, too many of our colleagues don't feel like they need to contribute, whether it's time or money. Money makes a big difference. You have to spend money to make money, and whether that's to contribute to a legislator's campaign or updating your staff education or your education on the things we've been talking about this afternoon. You can't stay in business unless you're willing to continue to invest in it and grow your business. And if you're not, find something else to do that you like more, or maybe go someplace where you get a regular paycheck. But if you want to have your own business and be independent to make your own decisions, then you have to do those things.
Yeah, you're in the path.
Yes.
Right. All right. Well, I really appreciate your time today. I think we've shared some really valuable points, and I appreciate your service of being out there helping our colleagues and being an advocate.
Well, thank you. It's been a pleasure talking to you today, and I hope I didn't preach too much. Sometimes I tend to preach a little bit on some of the things that I get passionate about, but a lot of our colleagues need to open their eyes and wake up and get their heads out of the sand and pay attention to what's going on around them, and not just isolate themselves in their own little world in their offices. There's a lot going on out there that affects them every day that many of them unfortunately are not aware of, and they need to be aware of those things. Otherwise, they're going to find themselves in a bad financial situation before too long.
Now I hope they'll take this as a heads up and
Yeah.
get out there and do it.
Yep,
All right.
exactly.
Well, thank you, and I hope you have a wonderful afternoon.
Okay, you too. Take care. Bye.